Hi, everybody. Good to see everybody. I just realized that it doesn't look like my earrings match, but they did match the Grogu surgical cap I had on, just for the record today, just saying. And I've decided that Chris's monthly webinars for me line up and have synced exactly with my team's 5 a.m. Monthly meetings. So perfect timing every month. So little worn down, had a great time at the Academy meeting with everyone else. So I did add some music tonight so that we could all stay awake and lively. And I also want to start, I know that, come on, don't be silly. There we go. Chris mentioned the Academy meeting, great time. I hope I get to see you if you're on here. And also several people gave me questions that I had written in my phone. Several people have texted me, emailed me. I think I've integrated everything. If I miss something, then just please put it in the questions and we'll get it at the end and we'll get to everything. And congratulations to all those newly pinned diplomates and everyone that had such a successful meeting. So the why. I want to talk about this because this was ironic. And I had a lot of questions at the Academy meeting from my friends. They're like, what is the deal? Well, why am I here? Why do I love doing this? Well, I love, and this is just a picture of me teaching in another country. I love my colleagues. Pediatric dentists are just the best people. And I mean, I think we average just like on average, one a-hole in the entire country. Everyone else is just so fabulous. So I love my colleagues and I love doing anything that I've learned in my 25-year practice career that can maybe make your life a little bit better. And also, you know, we all love the children and we just want to do the very best for them. We want to make their lives as easy as possible. That's why we went into pediatric dentistry. And I slid this picture in. One of the docs in our office actually sent this to Clark and I. Were at the surgery center stay together and said, hey, this friend just came in. Will the anesthesiologist put her to sleep? And of course, the answer was a resounding and giant hell no. She's a 3-year-old that weighs 60 pounds. And you can see from her neck that she is high risk for airway. And many of us don't have a lot of hospital time. We have minimal hospital time for high-risk children. So we're left with, we can't sedate these kids, obviously, that's not going to work. So we're left with having to be on our game with giving the most absolute painless injections, sweet talking these sweet little babies. So when they have a full mouth, we're trying to chip away at getting through it in the office, that they're still our friends when they come back. So this is real world daily business that we do. And all right, so I want to say, if you have not used a dental high-tech device, it is FOMO for real. It really, truly is a game changer. And I have had the privilege of using these devices since March of last year. And I'm not going to lie, there's a learning curve. And there's things that we're going to talk about tonight that I hope you can integrate to make things go more smooth for yourself. But once you get the hang of this, you can't imagine your practice life without it. And we know this is absolutely the situation. Our colleagues in other countries have been using them for years. The Dental High-Tech Academy is filled with many colleagues, mostly general, but several pediatric dentists. And a great pediatric dentist colleague of ours, his name is Nate, he's in France. And when I talked to him about his device, he couldn't believe we didn't have it. And then he said, let me just put this into context for you. If for some reason I showed up and my device wasn't working, I would cancel all my patients. I don't use a conventional syringe. And now we get to join what everyone else already knows. Special shout out to my dear friend, good friend, Anne. She made us our cute own little dental high-tech representing the states, little stickers here. So we're in with dental high-tech now, and we are part of the movement to help everyone in the US deliver this compassionate care that we know to be the very best way to do it. So there's many other people involved now with Dental High-Tech Academy. This is a list of all of our colleagues. And also there's 2 webinars coming up. You're stuck with me for a little bit. I think Anne is super busy with all of her leadership commitments, but I will be back June 12th and 26th. I'll be sharing my contact information soon. So if you would like to email, text, whatever questions to me, I'll be sure to include them. Or if you have a specific video you would like to see, for example, I want you to show me how you anesthetize removing primary canines for orthodontic extractions, which is an interesting thing because I have found, and Matt Lucero, who's also a KOL, he and I have had a discussion that, you know what, that canine prominence is a little bit denser bone. So you start picking up on these little things that you're like, okay, I'm going to angle it this way and I'm going to do this because it worked well that way. It will come to you, I promise. And then we go back to Anne. Anne's back lecturing July 10th. So I recommend you take her up on her offer to teach you too. And I'm sure she'll offer many pearls that I don't have on my lectures. All right. Also, I opened the door to Raleigh, North Carolina. We have 2 practices open 5 days a week for 10 patient care hours a day. Also, the Raleigh Children's Surgery Center. If you want to come spend some time with us in Raleigh, and just reach out to me, you can scan this code and you'll have all my contact information. It's a very rare week that we don't have a visitor from within the States or even outside of the States. Just a quick product comparison. When we were at the Academy meeting, I think this is one of the biggest questions I kept getting asked. Oh, it's just like the one. It's just like the one. It is not the one at all. One is single tooth anesthesia. It is periodontal ligament injections, and all these things have similarities, but only Dental High Tech has digital delivery with a pen grip and a specialized needle. So it is the only way to get all of the bells and whistles. I want to let you know, if you bought a unit at the Academy meeting, first of all, congratulations. Second of all, I hope you've already dove in headfirst into reading your manuals. I strongly recommend wherever you do your reading, whether it be your bedside or your potty or wherever you do, just put them there so you're tempted to pick it up. We've all, of course, had our reference manual for a while now, so you've finished reading back through that. So now it's time to read this manual. This will give you so many insights, and don't throw it away. Keep it. And I would probably not even leave it at your office because ours keep disappearing. And just make sure it's a safe place. If for some reason you have misplaced it, NewSmile, if you go to newsmile.com, go to Dental High Tech, go to your specific device, and you go to education or IFU, you can find the manuals again and read through the PDF versions. But please, please read these. Start with that. Secondarily, NewSmile has spent a long time with this onboarding program. So newsmile.com, products, NewSmile Tech. You can go to SOAN, scroll down, and then click on the onboarding, and it'll bring you through a really well thought out training program. And of course, I'm always open. Reach out to me anytime. I am your resource. I love my colleagues. I've already mentioned. I love to answer the questions, and I can help you out just the same. So exactly what we're doing. It's hard sometimes for us to wrap our head around what the actual goal is of local anesthesia. We're trained to do blocks, we're trained to do infiltrations, we're trained to ultimately anesthetize the nerve, but really what we're trying to do is just get it right at the apex of the tooth. We're trying to anesthetize the nerve before it enters the tooth. Now, we have been trained to do it 2 centimeters away, where the inferior nerve enters the foramen. We're trained to do all this, but the goal is still the same. We don't need all of that anesthetized. We just need where it enters the tooth. And that is the target right there. And I'm going to play something for you tonight. So every time you pick up your device, you remember exactly where you're trying to get it right there.
Let's do it. I like the way you do that right there, right there.
If you don't know that song, I'm sorry. It's a good song. It's an old one, but it's a good one. But that is what we're aiming for. And we're not trying to put the needle right there. We're just trying to fill the solution that surrounds the bone where the nerve enters right there. So we anesthetize it. Okay, so how does this happen? In a minute, you're going to see in this illustration, you're going to see the initial step of blanching. Oftentimes, colleagues are missing the boat because they're entering at the base of the papilla versus entering before it. The goal is that the bevel is centered on the base of the papilla. So you want to enter just a little bit beforehand. So you slide in just mesial, and you slip yourself in there with this beautiful Affitech needle, and you see the blanching. I strive for 4 to 5 millimeters. I can tell you, pediatric dentists, we do too much. And then you're going to come out and you're going to pop right through the bone. And once you pop in, you're going to start delivering your anesthetic solution. And basically, it's filling. Chris doesn't like me using the cannelloni reference of pasta, but we're going to call it bathtub. It's a nice bathtub that you're filling with this anesthetic solution so that it captures the innervation of the teeth and it anesthetizes them. And that's all there is to it. One thing to be cognizant of when you're doing your initial blanching step, if you're over blanching and you're not paying attention, and then you go through for your intraosseous administration, you've already burned some of your anesthetics. So you're falsely thinking you gave more intraosseously than what you have done. And I see it's a common error amongst our colleagues because we care so much. We really super duper blanch that first step. So just be cognizant of that. All right, let's go back to this primary dentition for just a second. Reasons why intraosseous is so effective and so easy and so nice with these dental high-tech devices is the cancellous bone for children. It's very easy to pop into, particularly the primary dentition, even early mixed. It gets more challenging as the bone becomes more denser as they age. Why do we want to do this versus a PDL? Well, PDLs can cause a lot of proprioception sensitivity after the fact. In fact, I think some colleagues have experienced where they thought they were doing intraosseous injections. They probably actually were in the PDL and their patients were a little bit sore, a little bit percussion sensitive. That's a sign you're in the PDL. Another sign we'll get to in a minute is when your pressure indicators are blinking, showing that you're feeling pressure, you might also be in the PDL. And if we're not here to get into all the studies tonight, I know the literature inside out, but there is also a study from a while back that would suggest when you give a PDL in the primary tooth, you are risking what we know, anyone who attended the COD lecture on molar hypomineralization, you're risking causing a disruption in the developing permanent tooth. So I personally do not do PDL injections on primary teeth at all. Okay, so when we infiltrate, we're basically coming at the needle, we're entering the soft tissue, and the anesthetic has to pass all the way through the soft tissue, but ultimately reaches the Volkmann canals and the Haversian canals. When you give an intraosseous injection, what is going to happen is you're bypassing the middleman and you're heading straight to the bone. So you're dropping right into the space where we can then fill basically the roadway of the bone, which is the Haversian, the Volkmann canals, and it's much faster. When we give an injection on the maxilla, as we know, due to the way the bone presents itself, we do get more diffusion. So we generally will get a few teeth forward and a few teeth behind. On the mandible, never bank on more than just simply one tooth distal. The diffusion will always be better drifting mesially or diffusing mesially, and we'll get into this a little bit more in a minute. So with pediatric, I'm just going to show one example, but when we give an injection, let's say we're going for the lower right quadrant right here, again, we're going to capture 2 teeth mesial and 1 posterior in this situation. And I'm going to show you a diagram in just a minute because it's hard for us to remember when we're doing intraosseous, we don't have this nerve thing. So there isn't a right and a left or maybe a little crossover in the midline. It's basically filling a tube. So you don't have to worry about right or left. You are simply, if you give a midline injection, it's going to anesthetize the teeth on either side, despite, one way or the other, as it would with a conventional nerve block. Also want to point out, in most of the studies that they use these devices in Europe, they have been using articaine way, way more than we have in the United States. They're far ahead of us on the articaine research and the safety. And in full disclosure, people who make Septicaine state very clearly that we are not to use it in children under 4 years of age. Of course, they're not. Those recommendations are not based off using Septicaine for intraosseous injections. They're based off conventional injections. So that's one thing to keep in mind when you're looking at this. The other thing to keep in mind is a lot of the former neurotoxicity and all these things have been put to bed. And I mean, let's face it, every local anesthetic is truly a neurotoxin, but we're just not constantly injecting people every day of their lives, and we're using such minimal amounts, it's fine. So with the articaine, when you're injecting the articaine, it's the preference, and we'll get into it a little bit more, but it's more lipid soluble, so it diffuses way better. And also, what we know from the data from overseas is it's also more effective with those teeth that have molar hypomineralization. And we'll get into that just a little bit more in just a little bit. So the special needle design, I tell people if you do nothing more than switch out your needles to Effitech, you've already done a favor for, we call our patients our friends in our practice, the friends that come to see you, because it is so very, very sharp. It is a tiny, tiny scalpel. And when you enter into the tissue in the proper way, not stabbing down into it, but making sure you're bevel down with the D for dental high tech facing out, you barely, barely, barely have to enter the tissue. And so when you look at this diagram, the bevel is down, entering mesial of the papilla, the D out to put the bevel in the proper place, and you slide in with approximately 20 degrees more or less. You are just barely sliding into the tissue, and when you deposit the solution, it not only blanches the soft tissue to show you what you're doing, and anesthetizes that tissue, anesthetizes the periosteum, which of course we know is the very sensitive part. There's a high nerve proliferation on the outer surface of the periosteum, so we don't want to hit that until we do that blanching step. And again, you have to go deeper if you don't have the D facing out, so it's a very important step in that. So how do we give an intraosseous injection? Well, the first thing we're going to do is blanch the mucosa, just like we talked about. Second thing is we're going to do the manual bone penetration, and then ultimately we're going to deposit the anesthetic. So one thing that's a little bit different, and we are all trained, not all of us trained. I wasn't one of my schools I was trained to do this, and one of my schools I was not, but many of us are trained. We never hold our hands in the mouth where we're injecting. We use a mirror retraction, and we do these things. It rather lessens our ability to protectively stabilize our friends. We call this the circle of safety, where we just don't turn loose, and we have a very good grip, just like this, the circle of safety. And you can see this little girl's brushing the little guy's teeth in the office, and she just naturally does it to hold that guy still and make sure everything's good. And the reason why we like to do this, particularly with intraosseous injections, is we want to make sure we have full control. We're using the pen grip, so we're very close. And if our friends are to move with this closeness, we will move too. And another song to help you remember the circle of safety.
Stand up, when I move, you move.
Just like that.
It's a true thing, and I can tell you, I see many friends with special healthcare needs in our practice, and even if you have someone that weighs twice as what I do, and they're in the circle of safety and they move, I move just like that with them, being stable, being controlled, and being safe with the pen grip on my dental head tech device. So being out of the tissue is still very important. It's not as much. The rule of thumb when you're given an infiltration and you're giving an infraalveolar nerve block is that we want 5 millimeters out. Why do we want 5 millimeters out? Well, very particularly the pterygomandibular muscles, if they are to capture a needle and retract, your needle will disappear. So you want to make sure you abide by that rule. When you're doing intraosseous, you only need to be 1 to 2 millimeters out. And just about that, just out of the tissue, just so if you did have a hub separation, you would be able to retrieve your needle. A hub separation, I've had one because I pushed the limits on an older moving special friend a bit, and I had my first hub separation, and it was absolutely no big deal. It's not going anywhere. You're not injecting in a muscle. It's just sticking right out of there, and you just reach in and pluck it right out, and it's the lowest stress possible. Absolutely. I would rather separate a needle in the bone than in soft tissue any day where it's going to disappear from my eyes. So something to think about, especially in this litigious society that we live in. For me, just the lack of concern about where my needle is could be potentially just enough. But of course, what's most important about this system is the compassion and delivering the care. Topical anesthetic. Some people using these devices still use topical anesthetic because it makes them feel warm and fuzzy inside. I absolutely don't. I have not used topical anesthetic in 15 months since I've begun using these devices. So we just gently use a nice fresh needle, do the blanching step, and then come out and go forward. And people say to me, oh, well, if I don't use nitrous, I think they felt it, or this or that. And we know from behavioral science, I learned this from Amir Morsi, that some kids are dandelions. They're just very resilient and, nothing really phases them. And some children are orchids. Frankly, adults are the same way, where everything has to be perfect. They're very sensitive. And if a child shows up and drives up in their car already saying something hurts, of course, there's nothing you're going to do to turn that around if they were stirred up before they even got there. It's not a magic wand, even though some call it that. But it is as pain-free of injection as we can possibly give. Yes, they might feel pressure, but it's fine. Just be responsive. And if you do have a child like, oh, immediately apologize. I'm so sorry. Let me fix that. I'm sorry, whatever you call your high-tech device, I call it my thermometer. I'm sorry, my thermometer pushed hard right there. I'll fix it. By that point, there's already a little bit anesthetic there and they're not going to feel it anymore. Okay, so everyone says, I don't always feel the pop when I go in the bone. Oftentimes you don't. And I think perhaps in previous webinars, we've over discussed this. You'll feel the pop go in. Yes, many times you do feel that, but sometimes your needle just disappears. It's got to go somewhere. And it happens to be through the cortical bone. Now, oftentimes you didn't feel it pop in, but when you go to take it out, you feel the resistance. So you know that you were in there. And you also can tell by the pressure. If the pressure indicators are not going crazy, you know that you are in cancellous bone. And I recommend when you're going into the bone, and you'll get where you're really good at this, rotating it a little bit in your hand to work its way through the bone. And when I come out with it, I rotate it a little bit as well so it doesn't go ha and like pull out real quick and then potentially poke them again. So just be very gentle and purposeful. So yes, it is a longer delivery. People like, oh, I don't have time for this. I can give another injection so fast. I can do it so fast. But everyone needs to understand it still saves time. If you put a stopwatch to a procedure using intraosseous versus using conventional, well, sure, maybe you can inject quicker. Is that what we want to do? The golden rule is 1 milliliter per minute. But the other part of this is you're not waiting for an infiltration to take effect. You're certainly not waiting for a nerve block to take effect. As soon as you're done delivering your anesthetic, you're ready to isolate and pick up the handpiece and get to work. Okay, the journey. Some people came up to me and just said, oh, I tried it. And everybody does this because they don't want to try first on a child. Oh, I tried it on my dental assistant. I tried it on my mom. I tried it on my associate. I tried it on someone and I bent a needle. Well, that's because you basically jumped out of the box and just went straight to the finish line on a journey. I don't recommend doing that. I recommend starting in the primary dentition. It's rather predictable. Take your time, take a deep breath. Everything's going to be fine. Making sure you alert the parents that this device is extremely compassionate and pain-free. Their child may feel pressure, but that is all. It does take longer for delivery. And do all the explaining, be confident in yourself, and start in the primary dentition. Start with a young child. A lot of people have great suggestions. I know one of my really close friends, Bobby, did it first on in-office anesthesia, general anesthesia in his office. A lot of people have done that. I've started doing that when I'm training new doctors to use it. And it's a great way to do it. But if you don't offer those services, just start with the primary dentition, which is what I did. And within a month, I felt really good. So I graduated and I started doing early mixed dentition. And then a month later, I felt good. I was doing late mixed dentition. And then over the summer, Dr. Prin took me under his wing and I learned a whole lot more about positioning. I learned about if I get blocked up or I bend a needle, it's best to go back to where I just was because I've probably already started making an entrance through that bone. And if you use the pen grip in the circle of safety, you would be amazed at how many times you drop right back into the exact same spot that you were in. So I had a little bit less fuggle then, and I continue to graduate on. And now I just can't even remember the last time I did an inferior alveolar, whether it's permanent dentition, primary dentition, or an infiltration, unless I was purposely passing past the mucogingival junction, which we'll talk about, or it was a big infection type situation. And you'll slowly begin to get your way, but just don't jump out of the box and try to jump into the permanent dentition. Ease your way into it. You will learn exactly how much force you can apply in the long axis of that needle and get it through the bone without so much frustration. So hang in there, but get ready for the journey. The needle design is something I really want to talk about for a minute. If you look at your manual, it will tell you that you can use for intraosseous the short green one or the medium white one. So the 9mm or the 16mm. And I am a rule follower. So when I would get to permanent dentition, I would immediately switch to the 16mm to try to do my intraosseous. And what I found is the pure physics of taking force and pressing it down, even if you're turning and you're focusing, you're in the circle of safety, you have your pen grip. The simple physics that the longer the distance that you're going to carry the force, the more likelihood you are going to get your angle of force off and cause yourself to have a needle bend. So I quickly learned super fast, and I feel like this was what crossed the bridge for me to be able to intraosseous everyone at this point, is if I'm giving intraosseous, I absolutely only use the 9mm needle. I just do. Now, did I use the 16 when I was learning and infiltrating? And yes, absolutely. Did I use the long one for inferior alveolar when I was still learning? Absolutely. Even though I was using it conventionally, it still was a more compassionate way to deliver anesthetic because the needle was superior and I was doing digital delivery, so I wasn't passing the solution too quickly where they were picking up on too much pressure sensation. One thing to note, and we're going to talk about examples of this in a little bit, when you use a 9mm needle and you are in the permanent dentition or possibly in the late mix, when you have an adult-sized person, so potentially if you want to go by the PALS guidelines, they think 9 and above is not PALS anymore. We transition adult, but when you have a bigger person and you're using a 9mm, you're actually doing an intraseptal now. You're truly not doing an intraosseous because that needle is not reaching down as far into the bone as what we would expect to do if we used a 9mm on a child in the primary dentition. So in that situation, I immediately switch my epinephrine to 1 to 200,000. And it's because I know I'm depositing the high volume of anesthetic intraseptally versus intraosseously, and I don't want to cause an ischemic crisis, which is not the end of the universe. A little ulceration, maybe a little bit soreness that's gone within 2 days. How do I know? I had learned the hard way. And I think a couple colleagues have called me and they've learned the hard way too. So when you transition to the late mixed and the permanent dentition, I strongly recommend that you use 1 to 200,000 on the epinephrine. And we'll talk about this more. I'm studying yoga. I'm a good yoga student. And during a workshop, this is probably the most pivotal thing. We had nothing to do, and you're not supposed to be thinking about work during your yoga, but the teacher said more doors are opened with kindness than force. And she was actually talking about hip openers, not intraosseous anesthesia, but it was an epiphany for me, because sometimes, particularly if you feel like you have a little friend, they're getting anxious, or you have a parent breathing down your neck, whatever the situation might be, and you're trying to rush, and so you're applying a little bit more force trying to get through the bone, you're more likely to bend a needle. You just take a minute, rotate the needle back and forth in your hand, finesse it through the bone. I like to picture it actually moving through the cortical bone and into the trabeculation. You will be just astounded. You will learn quickly exactly how much force you can apply without bending, and bent needles get further and further and few between. Just real quick on the prices, and by the way, I don't make any money off anything you buy. I am just a pediatric dentist like everyone else on this webinar, and possibly an anesthesiologist that was attending tonight that's a good friend of mine. But at any rate, these are the prices, and I know that initially New Smile worked out a workflow, And I think the workflow probably was calculated on someone that doesn't work as much as I do, but what you get in share time returned and other savings, it comes back in dividends to you. We have 6 of these devices. We have 3 of each. I personally like the sleeper one better, and we'll talk about why in a little bit more. So there's many options. People don't understand, just because you get this device and it shows up at your office and you're like, okay, let's do this thing. I'm ready to go. It's just a syringe. So when you are learning, I strongly recommend you don't have this for this and that for that. Set me up for this and set me up for that, because then you're just wasting everything. Just put away your conventional syringes, commit to the primary dentition that you're going to do intraosseous. However, when you have bigger kids and you're still needing to anesthetize them, you can still use these devices to do an intraalveolar or do an infiltration. And yes, it will take longer. And I think this is very funny to me because I have colleagues that make up names, and I'm going to tell you my favorite names a little bit later. But one colleague told me that she actually loved it when she sat down. She's still in the conventional stage for even early mix, but she said it's just a good reminder for us to get in a hurry, not to get in a hurry. Faster is not better. They're more likely to fill it, definitely more likely to fill the injection, and it gives you the opportunity just to take a breath, connect with the patient. And she kids me every time she picks it up. She reminds herself to be patient, and she says, I don't want a minute man, I want a sew-in. And so I thought I would put it in there so everybody could remember the value of taking the time doing things, because it's really true. Faster is not better. For those of you who kind of attended the Kellogg Leadership Institute for cohort 5, Go 5, we had a faculty there. And one of the main things he always said about success was go slow to be pro. And I think it's great advice in everything you do. Okay, other options for your dental high tech. Well, obviously you can use it for intraosseous, but you can also use it for intraseptal. As you can see in the middle diagram, one thing about intraseptal is it's not intraosseous. So when you're injecting between 2 teeth, you can expect intraseptally to get the tooth mesial and the tooth distal. If you want to do a full quadrant, you'll probably need to do more intraseptals. And I'm talking about, again, late mixed and permanent dentition. So keep that in mind. And of course, switching to 1 to 200,000 on your epi. You can also use these devices for PDLs. I just really have never been a fan of PDLs. I think they create a lot of pressure, and I find that people have a lot of sensitivity after the fact. But with the digital devices, it will not let you over pressurize, and you can use them that way just the same. So for 15 months, I like to talk about, what it's meant to me. I haven't used a conventional syringe in the office. We don't have these in our surgery center, but in the office, absolutely 100% haven't used a conventional syringe. I haven't done a block on the primary dentition, haven't done an infiltration on the primary dentition unless it extended past the mucogingival border. And I have not had a single chewed lip, tongue, or cheek, because none of the little kids have gotten any peripheral numbness, because from the very beginning, I committed to the primary dentition. I haven't used topical. I haven't had dominant hand pain, which is the right hand for me. And I want to get to the questions that some of my colleagues ask about hypomineralized 6-year molars. This is a game changer, and I'll show a couple articles later. And I know New Smile's in the process of working on putting those pieces of literature about the success, the increased success with intraosseous in regard to hypomineralized molars. Even if you ask the most seasoned of our dental assistants, those have been with me well more than 20 years, they'll say their estimation is 90% less tears. We don't like saying crying and singing with local anesthetic. The efficiency is increased for us. The profitability is increased for us. And I personally, thanks to Dental High Tech and New Smile, I have learned so much more about anesthetic agents and epinephrine selection, and it's just brought a lot more energy and happiness back. And I don't think that we really grasp every time we see a tear in our office, every time a child says we hurt them or something, it it hurts our soul. We bury it down because we have to get our job done. It's just way nicer to have kids just say, oh, I didn't even have to get a shot. So it's very, very, very important that we are conscientious about our wellness and our longevity in our profession. Burnout's a big thing in society today, and there's so much we can't control. So why not just do the things that we can control to make our life better? So I'm just going to leave it at that. And that's my dog, Daisy, who was, oh my goodness, recently diagnosed with Addison's disease. Didn't know yellow labs could have Addison's, but she's doing well now. And she loves that I have energy to play with her more. So chewed lip, this is parent's hand in this situation. And this picture, I love showing, there's millions of pictures I have of chewed lips, but this actually came from the pediatrician's office. The pediatrician took a picture and texted it to me. And he is one of the greatest, smartest guys. My son's pediatrician, as a matter of fact. And he's like, what do you think this is? I'm like, it's a chewed lip. That's all it is. It'll be fine. But oftentimes they think it's a burn. They think it's an allergic reaction, even though it only involves one lip. They think all these terrible things. And I've mentioned before in some of the webinars, we had a country hospital in a rural area in North Carolina. Actually, one of the other doctors in our office had something similar, and a PA re-anesthetized the lip and lanced the lip open to, quote, get drainage, and just the barbaric things that happen sometimes. So it's so glorious not to see this a bit anymore. As far as fingers, you're invincible. You're absolutely invincible until the day you're not. And these little ganglion cysts you see, and this is my left hand, my non-dominant versus my right in flexibility. And then you can see the little ganglion cysts. And this is actually after I had a few of those little guys and they deflated. Now you can't control holding the handpiece, but taking a conventional syringe and injecting like this is a big deal, and it will take a toll on you versus simply just stepping on a pedal and holding a pen grip and not even grasping it tight. I just basically support it in my hand because the children are usually not moving. They're usually oblivious. You're just hanging out, keeping it in the right spot and making sure that everything is in a good position. And I just want to show the residents made this for, and I just love it, the ECU residents, to show you how cool it is. This is now my future chief resident, Christian, there. These are graduating all full-fledged pediatric dentists, and congratulations. And thank them for making me that, because it was really cute. But it is, put it in the step, take it out of your hand. You're going to do enough with your hands for the rest of your career. And if you like doing other things, you'll get, I used to play instruments, and now I'm like, I got to protect my fingers. I don't want to even sit down at the piano. I don't want to do anything because I need to take care of it. And we all know this is true. This is the look of one of our little friends when they're worried, and you truly have one shot, pun intended, to win them over. So everyone needs to think about this. This is the apprehension that they feel, and you should feel too, because if you blow it at the injection, you've lost their trust for the rest of the appointment. That's fine. And they remember for the future appointments. So we really want to diminish the catalyst of the fear, because fear promotes the perception of pain, even if it's just pressure. So having a very non-threatening device, one that has a light on it, one that has a cord on it. Again, I love the sleeper one. I love that it has a cord. Cords can't be bad. All the fun things come with cords for children and their life. And I love if they ask me, like, are you gonna give me a shot? And sometimes I'll just kind of tip up the sleeper one a little bit. We have them both in our office so they can see the light. I'm like, no, just see that light? See it blinking? It's taking your tooth's temperature to come up, lie like a rug, whatever. Who knows? Maybe it is taking their temperature. I don't know. I don't know about that feature. But when you diminish their fear, you truly diminish pain, and that's what we want to go. So speaking of the sleeper one, this is what it looks like. Reasons why I love this one. And yes, it's less expensive. Someone said, is that your favorite because it's less expensive? Well, no, because we have 3 of each. But I like this one because I like the light goes completely around. It's very easy for me to see. And more importantly, it's easy for the child to see the light. They're very distracted by the light, and nothing scary comes from a flashing digital light. So I absolutely love that. It's also a wee bit lighter in my hand. And my hands, I want to take good care of them. I want to hold something as light as possibly be there. And we do have lefty in our doctors. Dr. Rosie Wynn is an amazing lefty doctor, so we don't have these mounted in our office. So they basically sit behind the chair and go which other side of the chair, depending on which doctor's there. And I don't find the cord gets in my way. I don't find it's a big deal. Even some of the little kids, they'll reach up and feel the cord. And for them, it's just like charging an iPhone or doing anything. Maybe it's like a little security blanket. We're not going to let them snatch it, grab it, or do something, but I just find it's extremely friendly. The pedals have 3 colors for different, and this is of course in French because I took it from the French manual, but the principles are the same. Blue always, always, always means bone. B for bone. And sometimes people will send me a video and be like, oh, I feel like they feel it when I'm injecting, and they'll have it in another color. I'm like, well, you know what? You're not injecting in the right setting, so don't do that. Don't do it at all. And no matter what color you are on, when you hit the inner pedal, it's drop by drop, always. So for the sleeper one, blue is intraosseous, B for bone, pink is intraligamental and palatal, and orange is infiltration and inferior nerve block. So it's super important that you remember, if you purchase a sleeper one and you are still in your journey of learning and you're doing a block, you have to be in orange to be able to aspirate, and you have to have used at least 1/8 of the cartridge. And there's different settings you can do. I would just not mess with it. And oftentimes what you'll see, because it starts out very slow and it ramps up to a faster speed, some children will pick up on the little bit faster deposition of the anesthetic. And if they make a or something, I just take my foot off the pedal and step back on it, and it restarts down at the slowest level again. It's that simple, but I wouldn't change the settings to speed up the speed. The SOAN is cordless. It's fancy. I like using it a lot. It just has lights on one side, and the lights, I feel like the lights aren't high enough where the kids can see them, so it's not a distraction to them. And of course, we have everything in our office: laughing gas, sedation, games playing, or movies playing. We have every distraction, but they can't really see these lights quite so well. And if you were only going to buy one, and you run multiple ops in your office, I see the convenience in this, but we do have, like I said, we have 3 of each, and I prefer the sleeper one. So the SOAN has only 2 colors, and the difference is, again, B for bone, but you also use blue for intraseptal and intraligamental and palatal, and then pink for infiltration and for alveolar nerve block. So if you have a SOAN and you are doing a block, you need to make sure you're pink. You need to make sure you use at least 1/8 of your cartridge, and then you're going to use the aspiration button. Couple things about the aspiration button. If you tap the aspiration button swiftly, it retracts your plunger. If you press and hold, it does aspiration. So that's one thing to think about. The other thing is there's 2 modes in the SOAN. You can cruise or you can drive. I like to drive because we have multiple devices, and when I sit down, whether it's a sleeper one or it's a SOAN, I like to know that when I press the pedal, it's going to go. When I pick the pedal up, it's going to be off. But there is a cruise mode where you can tap it once and it'll just go. If you are doing it infraalveolar, you have to then stop your cruise and then do your aspiration. Whereas if you're driving, you take your foot off, you immediately go to the aspiration, and it's fine to go. And if you want more instruction on that, just reach out to me. I'm happy to talk you through it on the telephone. There's a bunch of other fancy options with the SOAN. I frankly don't use any of them. I don't pre-measure the quantity selection. In fact, Jordan reminded me just the other day, I'm like, I don't know what's going on. We have one, it stops and I got to start it again. And he's like, yeah, someone turned on the quantity pre-selection. I was like, oh man. And then we just don't do that very often. So I have to go hunting for the manual and switch it back and do all the things. So I just leave it as it comes, and it does very well that way. Talking about needles, there's basically a couple things that you're going to want as a pediatric dentist. You're basically use the 9 mil and the 16 mil during the journey. You might graduate, if you're wanting to do inferior-alveolars, you can go up to the 35. Just know that's a little bit longer than a standard long that we generally use in the US. So don't bury that needle or you'll bypass your inferior-alveolar nerve blocks. But basically for infiltration, you know, they recommend a 16 mil, but for little tiny kids, if you are just, say it's your first week and you just want to use it conventionally and you don't even want to try to use it intraosseous, you can of course do that. And if you're doing a little anterior injection or something, you could use the 9 mil. But on the palatal, go short, intraligamentary, obviously short, intraseptal, short. And if you're doing infraovular nerve block, unless it's an itsy bitsy tiny kid, I would just say go intraosseous. Then you would want to go to the longer needle. But you can use for intraosseous, you can use the 9 for children. It says 16 for adults. I would say in my hands, it's just better to stick with the 9 and plan for the intraseptal so that you can get it there and reduce that epinephrine. And that's basically all you need to know. Just these main needles. So it is a single painless injection. There are exceptions where it's still not painful, but pressure is more detected. If you have an infection and you don't have a sinus tract, so the bone is already pressurized, it's already hypersensitive, and then you're dropping in and you're adding more solution, you're adding more volume to a pressurized situation, it only makes sense that the pressure is going to be more noticeable. So if you have one of those teeth, and you know what I'm talking about, where the child, they sit in a chair and you're like, let me see. And they just go, ah, you haven't even touched them yet. You haven't even looked at them. And they're just so sensitive, or you touch it, they're palpation sensitive. That is a pressurized bone. In that situation, you might choose to just do a teensy tiny little infiltration, not enough to cause a bunch of peripheral numbness, but enough to take that pressure sensation off of it, off the bone before you drop down into it. And you can see this diagram basically shows you what happens. And this is the 2 settings. So the straight line is how it comes. So you start not even at 1 milliliter per minute, and then it ramps up when you were in the blue setting. Very, very slow. So basically the device is not going to let you hurt somebody. And if it's so pressurized it's detecting it, it'll just stop. And it will not let you deliver the anesthetic. Other things to keep in mind, it's just radiographic presentation. We're not trained to read radiographs in school to deliver intraosseous anesthesia yet in the US. And I have some really awesome friends that are educators and KOLs for dental high tech, and I know they're teaching now. And when I have the opportunity to teach, I always talk about this as well. But basically you have to aim for bone and think about the communication of the anesthetic is through bone. So if you have what could be perceived as a roadblock in the bone, you might consider giving another injection, like a traffic jam right here where the infection is, and inject perhaps in 2 places. And then if you have large caries potentially pulpally involved, in another. For the sheer fact, think about the physics of filling a space. If you have bone loss because of an infection, and let's say perhaps you have a fistula, the bone is going to take more solution than it would if you were only filling the canals. So you might need to add more solution. So just think about things spatially, think about the physics of filling a fluid space, and think about what we're doing here. We're pressurizing the bone if there's not a fistula. And this is a great example, and all of us have seen it. Usually it's on the maxillary anterior where we're anesthetizing and there's fistulas. And as we're anesthetizing, even though they were 5 millimeters away from it, we'll see our anesthetic solution squirting out of the fistulas like a little exit sign. So obviously that's not effective, and obviously you're not in bone. You're just flowing it out of the soft tissue. So again, you would want to inject more than one spot to ensure we had profound anesthesia. Another little tip, and I think I have another slide, but this has been a game changer for me to have ultimate full confidence about my anesthesia. And this is, and I'm going to say it more than once tonight, when I'm injecting a single injection, so let's not say it's this situation. Let's just say, I don't know, let's just say I'm doing a pulp crown on tooth T instead of removing it. And I'm doing a single injection. Since it's pulpally involved, and as I'm injecting, when I get about halfway through that carpule, I'm going to pick up the shiny side of my mirror and I'm going to look on the lingual. And if I don't see blanching of the soft tissue, that's not my confident. I'm not confident. I'm not confident I've delivered enough solution where it's completely diffused through the bone reach the other side of the bone where it's touching that soft tissue, and the epinephrine is causing blanching of the tissue. So if I don't see that, I will either continue to add solution if it's pulpally involved or if I'm doing an extraction, or like in this situation, I would move forward and I would inject another space. So if it's pulpally involved or I am extracting a tooth, for my own OCD, I have to see contralateral blanching. That is for me, that's like running on a trail, being 20 miles in the woods. And I'm like, am I actually on the trail anymore? And all of a sudden I see a blaze on the trail. Okay, that's my confidence marker. I'm doing what I'm supposed to do. I can continue what I'm doing and do it confidently what I'm doing. So if you're just doing a basic restorative, I wouldn't worry about it. I wouldn't expect to have to see that. And it doesn't mean that you don't have soft tissue anesthesia. You can you can still put a rubber dam ring on there, do whatever you want to do, but profound to remove it or get into the pulp, that's what I want to see. And sometimes, again, I'll even come forward if I feel there's so much bone loss that I have more space than usual within the bone to capture that local anesthetic solution. And again, we consider the mucogingival junction the Great Wall of China. You are not passing that. After the mucogingival junction, that tissue does not touch the bone. Therefore, it does not have the opportunity to let diffused anesthetic anesthetize it. So in this scenario, you absolutely 100% have to go in and do an infiltration if you need anesthesia past the mucogingival junction. Do not forget that. If it were not for this chronic infection and erosion and inflammation past the mucogingival junction here, I would give a singular injection, one intraosseous right there. And because this is a very chronic thing, with the fistula, I would want to see blanching on the other side, and I would probably deliver more than half a carpule. I would probably go, depending on the size of the child, this looks like a very young child, I'd probably do 3/4 a carpule in that situation. And if I felt like I was losing some or saw some escaping out of fistula, I would probably reposition and give some more. The same principles apply whether you're doing conventional local anesthesia or intraosseous. We don't inject into an infection. We want to stay away from severely inflamed tissue. It's all the same. And the other thing is, if we're injecting in an area where there's a lot of infection, such as this last situation or the one before, and we were moving on to do another quadrant, it's best practice with intraosseous to change needles anyway. But even conventionally, if you've been in an infected place, you don't want to take that needle and go someplace else. It's best to change needles. Okay, so epinephrine and local anesthesia. I was trained, I'm sure I'm been practicing longer than most people on this call, but I was trained the gold standard for safety is 1 to 100,000 to make sure that we are keeping our local anesthetic where we want it to be and we're reducing systemic absorption. But the problem is this decreases the opportunity for diffusion and obviously due to the vasoconstriction. So when you're doing intraosseous and you're wanting diffusion, you're anesthetizing a quadrant, it is okay to go ahead and switch to the 1 to 200,000. And as I mentioned before, late mixed and permanent dentition, I exclusively use 1 to 200,000 now, because I know I'm actually doing intraseptal injections. So this is one of my favorite slides, and Dr. Print has showed it a million times, and I'll show it again, but the closer you are to the tooth that you are wanting to anesthetize, the less quantity you need. The further you get away from it, the more quantity you need. Similarly, if you want more diffusion, you reduce your epinephrine 1 to 200,000 versus doing the 1 to 100,000. And again, people say, can I use lidocaine? You absolutely can. Articaine is superior. A couple other small fun facts. Why is articaine superior? It's all about the thiophene ring versus lidocaine has a benzene ring. Thiophene is more lipid soluble, and articaine is broken down by hydrolyzation in the plasma due to non-specific pseudocholinesterases. We don't need to get into all that, but the byproducts are non-active, where lidocaine is metabolized in the liver and the byproducts are absolutely active. And I think I have another slide here that talks about those with special healthcare needs that we see a lot in our practice. And if you have a child that has been a long-term seizure disorder, on seizure meds, epilepsy, and they take those meds that are almost exclusively metabolized in the liver. Truthfully, we should be getting a consult every time and probably doing a liver panel every time to use lidocaine. The flip of that is when you use articaine, of course, it's always good to get a consult with sick kids, but because of the way it's metabolized, it's just not an issue. And the other thing I might have a slide. I have too many slides all the time, so I continuously take them out. But obviously, if someone has, a bleeding disorder and we're administering it intraalveolar, and of course, we would have a consult, but usually they require factor, which is extraordinarily expensive. When you do intraosseous anesthesia, you will find that the hematologists don't require to have factor. So it's just a win-win for everyone. All right, and this just talks about another article about articaine use in children and the safety of it. And by the way, our reference manual, if you look in our reference manual, which I read dog ear, highlight, and underline cover to cover every single year, it does say that that articaine is acceptable for use in children. But then the next sentence says, the manufacturer says, you're using it off label because it's not supposed to be used in children under 4. I do every day of my practice life. We talked about hemophilia and seizure disorders. I did have that slide in there. A couple things to be cognizant of, barriers to ideal needle placement. I found that most of our colleagues in Europe, they don't use nitrous oxide. The kids just sit there. They don't have movies and bells and whistles and all these things we do. So they don't really struggle around the nitrous oxide hood like we do. So when you're using, and I will tell you, I'm not as great as them. I use nitrous oxide for almost every single op I do. Just don't tighten that hood down super tight so you're not struggling with that or making it uncomfortable on their nose while you're getting that ideal alignment to pop into the bone. So I'm just going to talk about this one child. It's one of my favorite situations because it was very, very early on in my dental high tech and my intraosseous journey. So this was last July. So I had been using 4 months. And this is a 5-year-old well child that came in, and New Smile, Diane Kruger, the CEO, came in to video the situation. And so this child came in, he had 3 quadrants to do, and they wanted to have BioFlex crowns, and he weighed enough to use half a carpule in each of those quadrants, and that's what we did. So these are his bite wings, and what I did, and by the way, it's very different when you're using intraosseous versus using conventional measures. First of all, we wouldn't do 3 quadrants of dentistry on a 5-year-old using conventional measures, but let's say we were doing 2. You would generally anesthetize, and then treat. Actually, you would anesthetize, go check some re-cares and come back, treat. When you're using intraosseous, I do 1 quadrant, I treat it to make sure I'm not getting called away to do re-cares because it's not going to last as long. And then I anesthetize another quadrant and I treat it, and that's another quadrant and treat it. And that's what I did with this little guy. His name's Henry. So I gave basically 1.5 carpules of septocaine, and I did 1 to 100,000 in this situation. And this was the summary. Why do I have crazy floppy arms? Because they were trying to take photos of this as I was working. But I did 1 appointment, 50/50 nitrous. I did 3 injections. I did all of 6 molars with an isolite, and I did a rubber dam isolation for the 2 pulps and 3 BioFlex crowns. And including his photographs, he was out of there in 40 minutes. And I love this photo because I was so hyper fixated on, can you see and do all this? And I'll never forget, one of the dental assistants says, Dr. Johnson, B for bone. I was like, oh my gosh. And so I reached over and flipped it with my foot. So it's good that your team knows how to use these devices just the same. And this was Henry when we finished with his 3 BioFlex crowns, 2 pulps, and 4 sealants. And he was a happy guy when we were done. And this is the game changer. This is where it's just all worth it and no peripheral numbness. And that was it. And he was done. 1 shot, done with nitrous alone. Couple questions. People always ask me, who's the oldest patient you've been able to use the SOAN on? And or the dental high tech. So I see a lot of those with special healthcare needs. So for me, routinely in their late 20s, I have many friends that haven't been able to find a dental home for them. yet. So they're aging in my practice with me through my career. But however, one of our colleagues actually used it on her 70-year-old associate, she said, and it worked great. And that's a good point to make. Sometimes I have found people it's not as age dependent, is sometimes it is their heritage. Some heritages have more dense bone. People who are super, bradycephalic and they had this whopping mandible, you start sizing them up. Or I might have a 25-year-old special healthcare needs young woman with, say, Rett syndrome, and her bone is very easy to pop into, just like she was 3 or so. So don't get too caught up on age all the time. Just you'll start seeing people differently. You'll start looking at the size of their wrists and how tiny they are, or if they look like they're dense, if they have these whopping masseters, and you're like, wow, that's going to be something there. You start sizing them up very quickly. The pressure indicators. So on the SOAN, the pressure indicators are on the front, and you can see how it's 2 blinking now. It's a little bit more pressure. And I'm getting someone to film this for me, and they're caught up in what I'm doing in the mouth versus the pressure indicators. But you can see if you back out a little bit, sometimes it'll reduce, or just take your foot off the pedal for a minute. You'll go back to just 1 blinking light. And again, if it gets to 4, it'll just stop you and say, nope, you're done. And of course, I've already done the blanching step with this friend. You see me looking with the mirror. I'm removing these teeth. So I'm making, when I say blanching step, the blanching, the initial mucosal and periosteal, top level of periosteal layer step. And you'll see me look in the mirror because I want that confidence marker. And when I peeked, I could already see that it was blanching on the lingual. So I was super confident with it. So I went straight to removing these teeth. And you can see he did very well. Curate that and get that done. And this one, I've talked to the story before, but he was at the prize tower, and I was like, hey, are you doing all right? And he's like, I'm great, but I think your thermometer knocked out my teeth. He didn't even realize he had an injection or that he had those teeth removed. This is another kid. I love showing this one because I feel like I'm in Europe. We're not using nitrous oxide. So it's great. Again, the blanching step was done already. This is the intraosseous portion. And B for bone, going on blue. You can see how tiny this little guy is. She's not forcefully holding him. She's just making sure he doesn't reach up and grab something. You can see the cord reaching around, doesn't bother me a bit. I like it. And see how I twisted when I came out, so it didn't just like cut. And then I'm just going to remove these teeth. Both of these kids had whopping traumas that we tried to hang on to, and they had root resorption, so we weren't able to do pulpectomies to save their teeth. And you can see, you can watch his eyes. He's doing just absolutely stellar. And we're going to remove these teeth, and you'll see how tiny. The last little guy you saw, he was a 3-year-old. This little guy is not even 3 yet. He's 2 and change. He's an older 2-year-old, and we're just helping these teeth out, and he's completely oblivious. We're just gonna curate that granulated tissue. He's like, oh, that feels soft on my cheek right there, because his cheek's not numb, and he's feeling it, and then he's gonna be all done and out the door and ready to go. And for parents, you have to, again, remind them you're going to be there for a while. He's like, what do you put in my mouth? I feel that, yeah, I'm doing great. All is well. Happy little camper. And I just want you to see, not a tear in his eye. Everything is good. And this is the way it works. My practice partner, Clark, will say, the price of these devices just for the maxillary anterior on children is worth it all, because now we can give a pain-free maxillary anterior injection, where that was the tough one. You can be a good pediatric dentist and do a good job in other places, but not in those. This is an older child, just showing you can get through on those. And I want to make sure we have time for questions, so I'm not going to go through. One of the reasons I like showing this is you can see after my blanching step, it takes me a little bit to finesse and turn and get that through the bone. But again, I'm on blue, B's for bone, but I'm using the inner petal at this point, so it wouldn't matter what color I'm in. You're seeing it's flashing, so it's going. When you first get your device, you'll want to fixate on the cartridge, but if the light is blinking, it is flowing, so don't worry about that. And I'm going to keep going, so we don't just keep going. If you see blood after you do an intraosseous, it's just probably a little bit of marrow space blood in there. And the reason why is if you completely emptied the cartridge and it retracted, you actually did a little aspiration intraosseously, so don't be worried about that. The other thing to be mindful of, speaking of retracting in cartridges, is make sure that your team knows not to disassemble these devices until the plunger is completely retracted. The plunger is very sensitive. It picks up on pressure, and you do not want to damage that. So train them very well. I feel like it's something we cover at every team meeting to make sure new team members know this very important fact. Some people say, oh, I see Medicaid, I can't afford to do this, we'll take it. It's absurd. It saves so much time and money and chair opportunity and lucky day opportunity to convert recares into, sealants or whatever else the children need. So the molar, and we've learned, whoever was at the COD meeting with me, we're not supposed to use MIH anymore, so we'll just say MH, but we know the effectiveness of profound anesthesia is very challenging with local infiltration, and they estimate it's about 25.9%, where when we use intraosseous, it's closer to 90 in this specific study. This specific study shows a 93.5%. And it's just, for me, and I think this is my dear friend, Whitney Wignall, very specifically asked about this. I do believe this is one of your questions, Whitney. She asked if it really helped with this. And she also asked, is there anything I wouldn't use it for? So no, there's absolutely nothing I wouldn't use it for at this point. Early on, I would use it for everything, but maybe revert conventionally when I was still learning. And we all know this is the dreaded situation where we're like, no, and the child's probably already sensitive. And this is basically the sure thing to get these teeth profoundly anesthetized. And it's just sad. I feel during the lecture the other day, they said it's been around for a long time, you're just more aware of it. But I feel like I see more and more all the time. And again, situations of significant infection, I would inject on either side to ensure, again, I see contralateral blanching, and to make sure that the extra spaces aren't stilling extra solution or providing a roadblock to my anesthesia. My practice partner, I took a picture of him doing this. This is the initial step, the blanching step, the angle in the first panel. And we wanted to show two situations. I think sometimes people line in to pop in intraosseously, and they're just determined they're going to make it happen. And they twist and I'm going to push and push and push and push until the needle bends. Sometimes that's just not the right spot. It's okay to come out, re-angle, and try another spot. The higher you get up on the crest of bone, the more likely you can pop through and get into the intraosseous space. The further you get down, sometimes the more challenging, and there's not a sure thing on all things. The other thing to keep in mind is when you're injecting around a space that there has been bony remodeling due to a past infection or something happening, the bone is less organized in its deposition, and it's much easier to get into that space. Bone that has never been affected and is perfectly organized and laid out beautifully. And you can look at this on the x-ray, and you're going to start looking at x-rays, not only of where you want the needle to go, but you're going to start appreciating the periosteum and the cortical plate you have to pop through, and start sizing that up as well. And it all comes very naturally. So again, we talked about blanching as the confidence marker. My advice to you, if you don't see blanching, don't drop into the pulp. If you don't see it on the, and I'm not talking about the initial blanching step, the mucosal, I'm talking about you're injecting from the buccal or the facial, depending on where you are. If you don't see the contralateral side of the alveolus blanching a little bit, I'm going to do something else before I remove a tooth or I drop into the pulp. So just keep that in the mind. Now, the flip side is on the buccal, if you're thinking you're in the intraosseous and you start seeing blanching in the vestibule, well, your angle was too steep. You overdid the getting up on the crust of the bone. So you actually went into the cancellous bone, but you escaped out. And now you're just basically doing an infiltration. Fancy one, but an infiltration. So this is a little friend that had a K. Tooth K had a little lesion. You'll see it in just a minute. You can see the caries on tooth K. So this is the blanching step. And you can see I probably did a 5 millimeter circle there. And then we're going to come around and drop into that bone and just let it go. Now, you'll never, ever completely use a full carpule of a dental high-tech digital delivery, because the pressure sensor, you can see I used just half a carpule there, because the pressure sensor is so sensitive that it will retract before you get there. And I can tell you, I wish throughout my career I was stopped a little bit shy. Instead of using up every little last drop, my hands would probably be in better space. But this is basically showing, come out with a needle, little drink of water, and get to work. Wipe of the 2x2 and get to work. This is not our work from our practice, but I want to give you this one little tip. If you're still learning, as I was in this situation, I gave an infiltration because I wasn't exactly comfortable yet with mixed dentition, but then I tried intraosseous, and you can see I failed. I bent the needle, but this was a way for me to try to learn to do it with knowing I had a backup plan. And if sometimes I did get an intraosseous, I would just be able to start more immediately. And it's just a great little tip to get into it. And I'm going to drive on. This is a little friend that was referred for zirconia crowns in the lower arch. And oh, that French thing always turns the volume back on. This is a French slide set, French design. But just to show you, running out of time, but I basically did one quadrant, went out, checked recairs, came back and did the other. And this friend was out of there very fast. Talking about bone just a little bit more. So again, we're looking for infections, we're looking for fistulas, but we're also looking for a place that there's absolutely no bone. So if you look between teeth 1 and 2 here, and this is special friend that came to our practice, that'd be a terrible place to try to give an injection. There isn't bone there, so you have to seek where the bone is at. But for example, look at tooth 19. This is a delightful area for bone, and with that level of infection and chronic infection, I would inject on the mesial and the distal. And this, of course, would be an intraseptal injection because I'm using a 9mm on an adult dentition. One last time, do not go past that mucogingival junction. This is a situation where I removed 2 supers. One was palatal and one was very oddly on the facial, but obviously had to do more injection space right there. So what can rob you of your anesthesia? If you have a big kid, you need more solution. If you're further from the tooth, you need more solution. If you have more space in the bone due to bone loss, you need more solution. If you have a traffic jam or exit due to an infection, you need to inject in a couple places to make sure you cover all your bases. The angle of the needle, did you do an intraligamentary instead of an intraosseous, or did you exit the bone and infiltrate? It's not going to be the same. Did you get up and get talking to a parent? You don't get up after you anesthetize with intraosseous anesthesia, you stay put. And did you use the right anesthetic choice as far as epinephrine concentration if you were trying to diffuse your solution across a big distance? And finally, being cognizant of intraseptal versus intraosseous, because intraseptal is only 2 teeth. And I'm just going to show you, this is not my friend, this is someone else's friend, but this is just an example of one of our colleagues doing the blanching step. And this clearly adult dentition, that's a green 9mm needle. So this is intraseptal. And then you'll see nice long, definitely a pediatric dentist over blanching there in that situation. And then you'll see that she comes out, very long blanching step. That's a lot of blanching, and then pokes right back through there and comes back through. And you'll see it just drop in there. And that wasn't a pop, that was more of a slide, but clearly the needle's gone and that's where we're at. And there's a good bit of the needle still sticking out. And that's telling you that is an intraseptal injection. I can guarantee you this colleague, I feel like they all overseas use 1 to 200,000. You can see where she kind of turned it and worked it in just a little bit more. And what we were expecting for anesthesia in this situation is 30 and 31, no premolars. It's not an intraosseous. So we talked about giving 2 injections, what we do if we need to do that. Also, if it's taking you longer than you think, maybe you have challenging zirconia that you're placing in, space loss, crowding, something like that, you can go in and add more anesthetic if you need to. I want to just point out a couple of people say, what do you call it? I've heard tooth tester. These are just my top favorite. Tooth tester, magic wand, lightsaber that fights sugar bugs. One of my friends and colleagues, UNC friend, Allison Eggleston, she calls it Joanne the Soan. But my #1 favorite is Dr. Tony Sato, calls it Soana, and he sings it just like the Toto song. And I think that's super cute. So we talked about infiltrating. Yes, if in doubt, infiltrate. It's perfectly fine. If you're suspicious that something's going on, infiltrate. A lot of people will say to me, oh, emergency medicine and IO is the last resort. And just remember, a big difference in a 16 to 18 gauge needle versus a 30 and puncturing it through your tibia versus your cancellous alveolar bone. So keep that in mind. This is a more challenging case. I would show you me struggling through, but we're going to skip. And finally, I just want to get to the impact of your changing workflow. We have estimated in our practice that based on our gloves and the dental assistant that sits with us, when we anesthetize and we get up, the dental assistant normally takes their gloves off too and starts typing on the computer. The gloves alone per doctor in our practice, the equivalent of about $5,000 a year. So that's 7 doctors to the tune of $35,000 a year, plus the impact on the environment, plus efficiency, and again, happiness. So what I've learned, prepare the parents. This is going to be a long time. Most parents expect this to be like the pediatrician. They pop a shot right in their thigh, and this is not going to be like that. Ensure you retract that plunger so you don't damage your device. Train your team to do so. And remove the needle to release the carpule. Some people will leave the needle on and pick and pick and pick and pick at the carpule trying to get out. Just take the needle off and it drops out. When you get better at using these devices and you're moving through bone more rapidly, you will find that your pressure indicators are going off, not because you're in the wrong spot, but because you've passed through so much dense bone. Now you have an osseous lumen plug. So then in that case, you just come out, switch your needle, drop right back into that same spot. And I just want to throw in adding the value of dental high tech and dental high tech in the OR, especially with those with special healthcare needs, because they don't have that annoying anesthesia filling big fat lip, in addition to emergence delirium. And also we're not spiking the heart rate. We're not doing a lot of other things in there. Finally, if you didn't get my contact, there it is. It's my beautiful family. And I just want to give a big shout out. I need to get Chandler on this slide. I don't have a picture of her with the chicken bones. But I love this picture of Jordan. He has eaten his breakfast after getting bones ready for dental high tech workshop. And these guys are just great. And they genuinely care about helping us learn to do the best for our friends. So with that, I'll turn it over to these guys. Thanks, guys.
Thank you, Dr. Lurie.
Thank you.
Chris, did you want to go through any of the questions, or are you worried about your internet still?
Yeah, why don't you go ahead and go through those? I think I'm having some connection issues, so.
Sure thing. So the first one, any special discounts? The FOMO is real. Chris, do you want to hit on that, or do you want me to mention it?
Yeah, so good news is we have completely sold out of units after AAPD this weekend. So there is no more promo for AAPD. We will be taking pre-sale orders for the next shipment, which we're anticipating. So just reach out to myself or Jordan, and we'll go ahead and get you squared away.
Perfect. And yeah, so again, anticipating here within the next month or so. And then Dr. Lurie, this is a good question. I was not taught the circle of safety in school. Is there any resources to explain this?
All right, so this is, no, most people, I had one faculty member taught me the circle of safety at University of Tennessee. So the resources to explain this are, well, first of all, if you've ever been an expert witness on a hub separation case, which I have been 2 on, and both occurred, one occurred during inferior alveolar, when the circle of safety, the doctor has to shift to the 6 o'clock or 7 o'clock position to give an inferior alveolar, and they're unable to stabilize the head of the patient with their circle, their hug of their other arm. And the other was a maxillary anterior. In that situation, they were using a mirror retraction. So by using the circle of safety and staying at the 12, 11, 12 o'clock, or the opposite side if you're a lefty, staying in that position, that child's head is always safely nestled in your arm. And you and your angle on that, it's all locked into a very stable situation. Nothing's free falling. You have a fulcrum and many points of contact to stabilize that child. And I have seen so many things. I've seen doctors in our office who were trained to do mirror retraction, and the child jerk and scrape the needle and cut the child across their face. I've seen so much. And some people feel like, oh, what if I stick myself? If you have multiple points of contact and you close your space, your arms aren't, suspended, and you're closed in, you're just so much safer. And it's really important when you use the dental high tech, or it's important in my mind on all devices, but dental high tech allows you to stay in that 12 o'clock position because you don't have to come forward and swing around and go for a nerve block. And I will tell you that Dental High Tech Academy, all the European doctors all maintain the circle of safety. So perhaps the circle of safety is my catch term that now Dr. Pren uses, but maybe we need to ask him about some literature on that. He just calls it stabilizing, or he used to, but perhaps we can ask him about that. But that is why. And I understand it seems scary to poke yourself or something, but I promise you, the closer you are, the closer your hands are to what you're doing, you have more control, and it's way safer.
Awesome.
Good
Thank you, Lori.
question.
And then another one on that we kind of hit on earlier, but how would you compare these units to the STA, the WAN by Milestone Scientific?
So specifically to single tooth anesthesia, that's a PDL injection. And what was the other device? Did you say a couple other devices?
It was just the WAN spelled out.
There's different, so there's several devices where you're mechanically driving yourself into the alveolus, X-tips and things like that. And I mean, you can do that, but this is the only device with the specialized needles and the digital delivery and also the pen grip. So it's the only one that has all three of those key factors. So not saying, not this year at the Academy meeting, but the year before, I attended a course, and basically the doctor would take an endodontic explorer, a heavy duty explorer. He would do the blanching step, and then he would just drive the heavy explorer in and drop into the space. And it's just not as compassionate, maybe not as much finesse, but he's been doing it for a long time, very successful. Don't yuck someone else's yum, I always say, but no, this is much easier.
I haven't heard that saying before, so I'm gonna keep that one.
Never yuck someone else's yum, including their beverage choice for shots, Jordan.
Okay, well, that's debatable. That's here's one. How do you retract the plunger? I can answer that. You can either hit on the top left of the foot pedal, where as the reverse arrow, you can press that one time quickly, or you can, if you have the sew-in, you can quickly press the triangle button on the handpiece.
On the sleeper one, you need to use, there isn't a triangle button, so you must use the retraction on the foot pedal. And our team is very good, so they don't have to walk around the patient, because usually there's nitrous oxide hoses and things. They're very good at, like, before you go retract that, to remind us to do it, which I really appreciate.
And then what is the risk of hitting or perforating the root?
The root, so I mean, let's face it, people who do PDLs all the time, they scrape on the root all of the time. That's not what we're going for, of course, but I will tell you with these devices, if you get into the PDL space and you are up against the root, the pressure indicators are going to go crazy. It's going to tell you you're not where you're supposed to be, and it probably won't even deliver anesthetic. It'll probably retract at that point. So if you drop in, the other thing is the angulation. You're going to look at your x-ray. If you had some crazy dilacerated root or something going on, you would know about it and potentially not inject in that area. So you're staying between the roots. But I think, all of us have probably, especially with a child that's dancing around a little bit, maybe got off angle and maybe inadvertently did a PDL, but it's far and few between, as long as you keep them in the circle of safety.
Awesome. And then, oh, this one I've never seen before. So is there an association for high-tech dentistry?
Oh, that's a very good question. So I know Dental High Tech Academy, based out of France, and it's all over the country. They have a lot of resources, and that's what New Smile is building here, building educational systems. And I think you guys have some social media things that people can get on and join as well. and workshops and a network with really great KOLs. We have so many great colleagues that have already adopted this. And I think we're probably at the place where there's more than just me that's used over a year at this point, use the device. So it's starting to catch on. Just don't give up. There is a learning curve, like anything else. The first time you pick it up, you're going to have to learn how to use it.
Speaking of the top left of the foot pedal, also aspiration, any worries if you accidentally step on it instead of the outer pedal at the start of the intraosseous injection? That brings up a good point. If you'd like to kind of go over how you position your foot on the foot pedal, that's a common one I get.
Yes, I do. I do have, not to pick on the guys, but you guys aren't used to being up on your tiptoe, like wearing high heels. And I feel the guys and their feet generally are a little bit bigger, will accidentally press both pedals frequently. So that's a pedal mishap. And my understanding from you guys is if you do it, just switches it to drop by drop. I feel like in inadvertent times where some of the guys I've seen it use in our office, I feel like it just doesn't go. But at any rate, you do need to be you'll get where the pedals get a little bit easier, but you do want to be on your toe for the inner pedal. And if you accidentally press and hold, you'll get where you're so attuned, you'll feel the aspiration. It makes like a little noise, and the sound makes a beep. You'll feel it in your hand when you're aspirating, unless you tapped it fast. If you tap it fast, which you wouldn't do if you thought it was an outer pedal anyway, but if you tap and hold it, it will just try to aspirate, and you'll be very aware of that, and you'll just take your foot off the pedal. It's very obvious, and I can feel it. I've done it when I was doing inferior alveolars with it so much. I could feel it in my hand, like start the aspiration process. So I don't think that would happen, but it certainly wouldn't hurt anything. If you tapped it quick, it would retract to your plunger, and depending on how far you were into the carpule, you'd probably flip it into a higher speed, take it out of the kid, let it catch back up with where you're at with your solution, and then put it back in and continue on.
You mentioned the nitrous hood being in the way of angulation. Have you considered trying this with the slim profile single-use nitrous noses? I've always used the bulky nitrous nose hood to block the patient's vision, so I prefer traditional.
I love that question. So if I had my way and cost wasn't a thing and there wasn't overhead in the practice, I would exclusively use silhouette nitrous oxide hoods. They're so superior. They come in better sizes, they have a little adhesive strip, and when you do sedations, they even have a capnography port. They're magical, but they're also expensive. So we only use them for sedations in our office. So we'd consider that, but yeah, now I just kind of work around it. And it's really just the beginning when you're administering your local anesthesia. Once you're done with that, you just kind of go back to where you started. But we use disposable inserts in an outer hood is what we currently do.
The video feed froze when Chris was discussing the discount. Again, Chris mentioned it again. So his internet is obviously awful. And so we did run out of units. We sold out completely at AAPD. So currently we are roughly about a month away from receiving more units, roughly around end of June, early July. So we do have wait lists for that. Currently, there are not any specials. We have no units, so we do not have any promos at the time.
I like that Jedi mind trick, though. You were about to tell me about. I love that. I love that. Hey, by the way, though, I do think they have some sleeper ones, and again, that would be my preference.
Okay, so Laurie brings up a good point. We have a handful of sleeper ones left. If you prefer the corded unit, that's absolutely right, Laurie. We're still honoring. Right. We can still honor the APD price for those. There's what is there, Chris? 3, 4, 5 of those left. So
5.
So we have 5 of those left. We have a 10% off discount for those remaining 5 units through the next tomorrow, Thursday, then Friday. So.
And again, people cross this is real true. I don't make any money about anything these guys sell. I'm just a pediatric dentist like you guys. But are you guys still doing, I'm actually a little bit salty and jealous about this, but are you still doing the scanner sleeper one deal?
Technically, yes. Of those 5 remaining sleeper ones, if we for the scanner, our promotion from AAPD was if you purchase the scanner, you do receive a free sleeper one unit. So if you'd like more information on that, or even purchasing, there's a question here as well about obtaining the sleeper one, please email myself or Chris. I have the questions blocked as our yes. Please shoot over an email. You can do so right now if you'd like, and I can reach back out with you tomorrow morning, and we can discuss, or Chris as well.
Ah, mi amiga Milka. Hola.
And then Dr. Campbell asked, where's the cord connected to sleeper one? So essentially, the cord is connected to a little white box that is then connected to a power bank that plugs into an outlet. So you have plenty of cord. I think Lori can probably attest to that. But yeah, essentially just kind of, it essentially plugs into what is a power box that plugs into an outlet. And then the foot pedal is entirely wireless. So that foot pedal down there in the picture of myself is the sleeper one foot pedal.
And the
Pricing for
sleeper, not
ahead,
to
Lori.
be like neener, but also that foot pedal you see on the table beside Jordan, you'll notice that the foot pedal for the sleeper one has a green inner pedal. The sew-in has a darker gray. So for me, I wear loops when I practice, and my peripheral vision, I feel like, is a little bit limited by that. And I am able to peripherally find the difference between the difference between the green pedal and the gray pedal. That's another thing I like about the sleeper one, but not what you were talking about. But yes, there's the cord. That's how it works. And if you have all righties in your office, you can mount it. So it probably make the cord even less of an issue for you. I'm sorry, Jordan, go ahead.
No, that was wonderfully done. Thank you. And then the price of the sleeper one retail is $2,500. Honoring the last 5 units for the APD pricing was $2,500. So 10% is $2,250. So for those remaining 5 units, that's where the special lies on those.
And again, the scanner deals of, if you haven't switched over to digital scanning instead of green stick or Algent impressions in your office, that would be something to look into, because the sleeper one, again, as Jordan said, it comes with the scanner.
Awesome. Yes, how much are the needles? So the needles are $27 for a box of 100. That's just what the pricing of them is. So 27 cents per needle, I believe, is typically on average around 8 cents more than a traditional needle. So not that much more expensive for a proprietary needle.
Yeah, it is. Ream is very, again, I tell people, even if you just bought the needles, you would do a service. Even if you just bought the needles and used the devices but didn't go in intraosseous, it would be more compassionate. But then throwing everything at our patients is definitely the way to go.
Jordan, can you, just in case I get cut off again, can you quickly go over the available resources, the onboarding process, and the Facebook group for everybody?
Yeah, great point, Chris. So there's a few ways to train outside of the webinars. We have onboarding modules that are training modules for you to go through. You can then get on a virtual call with myself or Chris, where you can go further into the settings of your device, a little bit of technique and training. And if you do the onboarding modules and then the virtual meeting with myself or Chris, you'll receive 2 free boxes of the extra short needles as well. Chris also mentioned the Facebook group that is called SOAN/Sleeper One user group on Facebook. So if you search that up, it's just SOAN/Sleeper One user group. That's a Facebook user group dedicated towards current users to, pick each other's brains, ask about, certain cases, maybe struggles, help each other out. So that is a very good Facebook group to join if so. And then Dr. Sato, stop worrying about the costs. My sewing is 100% worth it. That's, up to
Thanks,
the
Doc.
doctor there.
We also have a few restore workshops coming up where we do a second day for just New Smile Tech. So KOLs, clinical trainers get hands-on experience with a dental high-tech devices. So next one is at the end of June in Boston. Hopefully I'm not breaking up here. Everybody can hear me, but Boston at the end of June. We have
Chris, I think Jordan and I should take over
Yeah.
because you're
Yeah.
breaking up, making
ahead.
weird faces.
Yeah,
Sorry.
So,
yeah, just
so Chris was saying at these programs, so in June, I believe the 22nd is the restore course, and then the 23rd is the dental high tech half day course, where what broke off was you can use these devices on the chicken bones, so you can really feel what it is like to pop through bone and deliver the anesthetic and practice going through the steps and doing so forth. So I know I will be in Boston in June. My dear friend Paul Bond is teaching the dental high tech portion. I will be his sidekick. And then moving forward, I believe Vegas is October 3rd, 4th. And then I believe that the weekend before Thanksgiving is Newburgh, Oregon, wine country. And then Philly in December, right, guys?
you got those down, Lori. That was impressive.
I know everybody's getting tired. We're gonna turn it out. And I will for sure be in Boston and Oregon. So I would love to see my friends there.